Great, so thanks very much for that kind introduction. Alan's going to push the button because geriatricians are technically challenged. So I was going to talk today about inpatient geriatric assessment and how to look after older people in hospital. And I was going to focus mostly on the subacute phase, but a lot of what I'm going to say also applies to general internal medicine. Apart from, I guess, making my living doing this, I don't have any conflicts of interest. I would like to acknowledge the Division of Geriatrics. You know, it's a bit like bringing coal to Newcastle, giving a talk like this to people with whom I trained, or under whom I trained. And I'd also like to thank the section in Manitoba for doing all the real work while I'm out gallivanting around here. So I would like to thank those people. So the objectives today, one is to talk about common hospital-acquired problems that older people face in hospital, and then to talk about how to avoid them, and specifically to talk about the model of care that's important for an older person. And I won't focus so much on the medical care, which I think we do quite well. I'll focus more on the other issues of care, the care environment and the care style and the model of care. But not to forget, obviously, the medical care is also important. And this is what I'm going to say, and I think it's fairly obvious, but I'll try to make it entertaining anyway. The first point is that frail older adults are common, and they're more common in the healthcare system than they are outside of it, and their hospital care is more complicated. If they're looked after in a model that has an evidence base, the rates of hospital-acquired disability are actually lower, the rates of institutionalization are lower, and that's obviously what older patients want. And it's also good for the healthcare system because it reduces some of the pressure on long-term care and on acute care. So that's what I'll say. So this is, I used to attend general medicine CTU, and this is one of the last patients I looked after, and the resident on the service was really excellent, but she insisted that people keep the problem list to 3 problems on walk-rounds. So the medical students couldn't talk about more than 3 problems. So the case went something like this. Mr. S is an 83-year-old man transferred from ICU with sepsis and delirium. Problem number 1 is he had sepsis, he had line sepsis, growing MRSA, and he's on IV vancomycin, vitals are stable, and he's afebrile. Problem 2, renal failure. He's been going for regular dialysis. His fluid and electrostatus have been normal. 3, delirium is much improved. He's alert and oriented. And the resident said, well, that's excellent news. That's just great. And she turned to him and said, that's great, Mr. S. Things are going just really well. We'll have you walking out of here in no time. And he said, well, how am I going to do that? I got no legs. And without missing a beat, the medical student said, problem 4, no legs. And we kind of laugh, but I think this is illustrative of some of the issues we're facing in hospital stays. And I think one of the important things when you're looking after a person is to kind of have a zoom lens, so that it's very important to zoom in all the detail and get all the problems and list them all and have a plan for all of them. But it's equally important to just be able to zoom out and see the whole person and see where they're going. So when you zoom in, you see quite a number of problems, including multi-organ failure. You know, he had multiple problems in the single organ, and then he had multiple organs involved in other problems. He also had IEDL impairment in the community. He lived in an inner-city hotel on the main floor, and most of his day was spent trucking down to the bar right next to the hotel. So again, that's not not an uncommon person in acute care these days. And you have to say, well, why is he in hospital? In fact, why is anybody in hospital, and what are hospitals for? And hospitals have been around for at least 1,000 years, and they have different roles that they have in society. They have the role of curing the sick, they have the role of caring for the disabled, and they have the role of segregating those who are felt to be a danger to the rest of society. Now, these are often presented as conflicting goals, you know, care or cure. But in reality, they're obviously complementary goals. It's difficult to rehabilitate someone who's medically unstable and not getting optimal medical management. Conversely, it's difficult to get somebody better functionally without rehabilitating them and only attending to the technical aspects of their care. So they're really not contradictory roles, they're complementary roles. Now, the general principles of geriatrics were laid out quite a while ago. So how many in the room were born before 1943? So the key papers were actually written quite some time ago. And it's important to note the dates. So times are difficult now, but you know we're not fighting Nazis. So you know it's not too difficult to enact these general principles. So this is December 1943, and the father of geriatrics was actually Marjorie Warren. And she took over initially as a hospitalist, a house officer in a peripheral hospital, which then acquired what was called a poor house next door. And the poor house was full of older adults who had very few social supports, poor functional status, multiple morbidities. And they had been housed there more like a warehouse than a care facility. And she, and not just her, but the rest of the healthcare team realized that with careful attention to their medical status, their functional status, and their social environment, a lot of those people could be rehabilitated and gotten home to their own homes. And she wrote 2 seminal papers, and then subsequently there was a report to Parliament in 1946. And what they did is they renovated the units. So again, it wasn't the Waldorf Astoria, but it was significantly nicer than it had been before. Verandas were put on, rooms for day activities were put on, meals were provided that were appropriate. Again, it's not particularly rocket science or high-tech stuff, but it is good basic care. They actually had adequate nursing staff, adequate attendant staff. They had recreational activities for the people. And they encouraged participation in regular activities of daily living to reintegrate them into the community. And the other important point is friends and family were encouraged, whereas before that, friends and family were actually discouraged from coming in. Now, the other key thing that they did was have a team approach. And actually, it's quite interesting that the team actually would be recognizable today with physiotherapists, occupational therapists, and social workers. And they stressed the importance of social workers. And attention to the social situation, not just in providing good care, but also in discharge planning. The other thing they did is encourage early ambulation. Now, it's one thing just to encourage ambulation, which they did, but they also had to create an environment in which ambulation was possible, so clear, uncluttered hallways and so forth. And again, they also got them engaged in their own activities and got them dressed in their own clothing as quickly as possible to reintegrate them into what would be the community at the time. Subsequently, they wrote a series of papers talking about the problem around patient flow, what we call patient flow today, and many of the words were actually the same, so they did use the word bed blocker in the 1950s. Even the nomenclature and wording was often the same. And they stressed that the way to improve patient flow is to improve patient care. So it's easier to get somebody home if they're actually functioning better than just telling them to go home. And also the importance of reminding us that numbers are important, quantitation is important, and understanding patient flow is important, but we should always remember that those numbers represent our mums and one day us. So we do have to remember that. Now, these thoughts are echoed today. So there's a series of quite nice papers in Annals of Internal Medicine and New England Journal which reiterate some of these messages and talk about how we can compare inpatient care of older people to pediatric care. And how many of you have done your pediatric rotations? So I haven't been to a pediatric hospital in quite a while, but they do seem quite nice. There are recreational activities, they're quite well painted, there's a lot of recreational therapists. It is a bit different than the situation in adult medicine. And I think although the principles were laid out in geriatrics, they also apply to other areas, and we should be learning from those areas. Now, when you look at what Warren, and not just Warren, but some of the other geriatricians wrote in the 40s and 50s, it's actually quite similar to what the models of care that I'll talk about in a minute, acute care of the elderly units and help programs, hospital elderly care programs. So the first key point is a prepared environment, so it has to be an environment in which people can walk, in which people can get around, and in which mobility is possible. And if you think often modern hospitals are a bit of a steeplechase, and healthy, fit young people on the house staff can't get down the hallway, it's much more difficult for an older person to get down a cluttered hallway. So the physical environment is actually quite important. Now, they talked about specialized equipment, but by specialized, they meant shoes and good walking aids and walking equipment. They didn't mean a lot of fancy schmancy stuff, but just good walking shoes. And I see most people here wearing pretty sensible shoes, except maybe geriatrician in the room. So good footwear is actually quite critical. Patient-centered care. So it's important to know what our patients are thinking, what their families are thinking, and it's important that they know what we're thinking. We might not like what they're thinking, and they might not like what we're thinking, but we should at least know what each other are thinking and what their discharge plan is and what our discharge plan is. Because we should understand that, and the care should be patient-centered. The team members then were surprisingly similar to the team members now. Discharge focus planning is more of a focus now than it was then, although that was mentioned. It wasn't part of the planning program. And then one of the differences that I'll come to between some geriatric models is an attempt to disseminate geriatric principles to the whole hospital versus an attempt to create specialized wards. And then again, all of them have attention to nutrition and feeding. All of them tried to have activities, and all of them tried to have early ambulation regimens. So why is all this kind of non-medical stuff important, and what are all these non-medical stuff which are quite related to medical issues? Why is this all important, and what are some of these important factors? And I think one of the key things is that we talk about all of these adverse events that can happen in hospital, and we focus a lot on falls, delirium, pressure sores, dying, worsening disability, readmission. And the key important point is it's the same people who are at risk for all of those different adverse outcomes. So if you look at the fall prevention, the fall prediction instruments, they look a lot like the delirium prediction instruments, which look a lot like the pressure sore prediction instruments. And it's the same general people that we would consider frail who are at risk. And the second key point is it takes a lot less time to get sick than it does to get better. And often that recovery lags the biomedical illness. So you can get quite ill quite quickly, then your biomedical status resolves, and then it takes longer for the cognitive and functional status to recover. And the other key point is it may be incomplete. And it's difficult to predict who's going to recover and who's not without waiting to see. So those are kind of important issues. And what are the specific syndromes? Well, functional impairment. So the ability to do your activities of daily living and your instrumental activities of daily living is important. And about a third of people who even aren't all that old, so 70, leave hospital with a new disability. So that's a fairly significant risk. The other important point, and this has come out of some longitudinal data from longitudinal studies, is that a good half, not quite, but almost half of disability is acquired in acute care hospitals. Now, it's not necessarily saying that hospital causes it, but it is acquired in hospital. So even small benefits in functional status improvements in hospital may impact the community disability rates quite significantly. So functional status is important. Now, when you think of how functional status can progress, you think of it pretty much as you would think of any major syndrome. There are underlying predisposing factors, there are precipitating factors, and then there's perpetuating factors. So the people who are at risk of functional decline in hospital, I don't think this should be a surprise to people, but very old people with a lot wrong with them who have functional impairment, cognitive impairment, major geriatric syndromes, poor social situations, and depressive symptoms. Those are the people who are at risk, not just of hospital-acquired disability, but of all the major geriatric syndromes. Then you add in the big precipitant, which is usually a chronic exacerbation of an underlying illness or a new acute illness, which is essentially an insult to a person. And then you have factors that can perpetuate the disability. So the hospital environment, restrictions to mobility, poor nutrition. We often enforce dependence, either through lack of adequate attendance staff or through the hospital environment or through just waiting for tests and being in tests all day. And then after discharge, those same factors can perpetuate the disability. So you can see a lot of room for interventions to reduce that risk. Now, I don't want to suggest that this is the only factor, even the major factor. This and this are probably the major factors driving hospital-acquired disability. But if we can fix some of these, we probably should. And why do we care? Well, It's a very strong predictor of dying, and this is a consistent finding across epidemiologic studies in the community and hospital and long-term care, is that functional status is one of the major drivers of mortality. So, you don't need to blow up a Kaplan-Meier curve to show the differentiation between people who are of good functional status, intermediate functional status, and poor functional status, so high-risk groups, intermediate groups, and low-risk groups. And no matter where you look at this, functional status is the strongest driver of health. This rarely surprises people on the street. If you walk down to the Tims and say, I know a 90-year-old who's so sick he can't lift his head out of bed, most people would understand he's sick. Often we don't ask that in the healthcare system, so we should be looking at functional status and considering it early on in the stay. Now, the real reason we should care about functional status isn't that it predicts mortality, though it's what our patients want. So very consistently in surveys, the main goal of an older person is to improve their functional status. And importantly, it's more important to older people than staying alive. So our goals are almost always to keep people from not dying. Their goal is often to get better and to go home to their garden and to improve functioning. So it's very important to clarify those goals. Often, actually, we get in geriatrics, we get in trouble the other way, where we think their goal is to get home and get to their garden, and really they just want to live longer. So we should ask people what their goal is. And people can tell you, as long as they're reasonably cognitively intact. You just ask them, what do you want out of life? And they can usually tell you. So it's important that things that improve functional status are what patients are wanting out of the healthcare system. And then the other really important point to make is that functional status is a barometer of health. So do you have the term, raise your hand if you've used the term dyscopia here. Yeah, so the house staff use dyscopia. It's a problematic term because people dyscope because they're acutely ill. So acute functional deterioration is almost always due to acute illness. Chronic functional impairment is due to chronic illness. So if you've got somebody who's walking their dog in the park for 5 miles a day, who suddenly stops doing that, that's due to acute illness. It's not due to social factors. So it's actually important to consider functional decline as a barometer of health. So the first one is functional status. The next important point is mobility, which is related to functional status, of course. And again, we should remember that hospitals are often present some challenges to people who are older and more frail, and in fact are younger. So it's often difficult to navigate the ward if you're a young, fit person, let alone an old person. The hallways often have beds, they often have rotolifts, they often have Saralifts, they often have linen sheets for MRSA and things like that. So it's actually very difficult to ambulate down the hallway if you're an older person. So the physical barriers are important. Equally important are technological barriers, so central lines. There's an interesting title of a paper called "A Foley as a One-Point Restraint." If you are going to restrain somebody, that's probably a pretty reasonable place to start. So we should be getting rid of these technological barriers as soon as we can. Because they're important. Staffing levels are important, and we often don't pay much attention to the nurses' aides, but they're probably the most important people in the hospital. They're the people who have the most contact with the patients, who talk to the patients the most, and who encourage them to walk the most. So they're actually very important people in a hospital. And then the last thing that we should never forget is deconditioning. So if people are put to bed for a prolonged period of time, they do lose a significant amount of their muscle mass and their muscle strength. So acutely, at least, it's 3 or 4% per day. So the longer you leave somebody without walking them, the more deconditioned that they will get. And that's actually an important point. So it's actually quite important to intervene fairly early to prevent some of these things. So we looked at our mobility on our inpatient unit. This is the work of Sandra Weber in physiotherapy, and we put pedometers on inpatients. And we found that on our inpatient units, first, it's very variable how much people walk, like very variable. Some of them are walking almost as much as a community-dwelling older person walks, and some not so much. The average is about halfway between older adults in acute care and older adults in the community. The other key point is that they don't walk for long, so we have to be very patient And we have to make sure that there really are chairs upon which they can rest. Because they only, at least on our unit, they only make about 3 minutes, stop, rest for a minute, and then go for another 3 minutes. So the physical environment becomes important when you're talking about fairly low levels of ambulation. The other thing we found that's not on this graph that we're a bit, initially a bit worried about was the fact that a lot of the ambulation actually happens after hours when families come in to visit. I don't think now that's necessarily a failure. It's probably good to be involving families and having them get up and about and bringing them down to the cafeteria for supper and getting them out. The other thing we didn't see, because there weren't many smokers, but smoking does seem to be in other studies in nuclear power and ambulation, that smokers tend to be up very fast. And they tend to be outside smoking. So bad health, I'm not encouraging smoking by any stretch of the imagination, because it does kill you. But it does make you march better, give you something to walk. Now, the other thing we should acknowledge is this isn't exactly new information. So this is from JAMA in 1911, and it says, you laugh. So rest is a therapeutic measure that's fraught with hazard. Prolonged periods of recumbency and bed are anatomically, physiologically, and psychologically unsound and unscientific. So that was 1911. In fairness, surgeons are probably a lot better than we in geriatrics are and internal medicine are in getting people up and about. You look at surgical units, they get people up very quickly, and we probably do have something to learn from surgeons. Another important point is sensory impairment. So we should make sure that people have their hearing aids in their glasses. Now at this point, everybody's thinking, well, who wouldn't get a little old lady their hearing aid in their glasses? But when you do walk-rounds, look at how many of your patients have good shoes, their hearing aid in their glasses. So it is important to get early on and quickly. Often the hearing aids get lost in the laundry. In some hospitals they get taken so they don't get lost, which is also problematic. And glasses can get lost. So hearing and vision are important things to assess, and it's not difficult or expensive to do. Depressive symptoms. So again, depressive symptoms and depression can impair rehabilitation, can impair treatment adherence. So it's very important to ask about it. Now, it's important to at least ask, have you been sad or depressed in the last 2 weeks? Now, I'm not advocating necessarily screening all older people for depressive symptoms or advocating early treatment with an SSRI, but it is important to understand our patient's psychological status and talk to them a little bit about whether this has made them sad. Now, cognitive impairment in hospital is a whole talk unto itself, but suffice it to say it's important. And there's 2 major syndromes that are important, dementia and delirium. So people with dementia are about 3 times as likely to be admitted to hospital. So dementia is a very significant risk for hospitalization, and it's also a risk for adverse outcomes when people are hospitalized. So it's very important to consider a previous diagnosis of dementia. And it may be unrecognized at the time of admission. Delirium is also equally important. So a good 15% of people are delirious when they come, and another 15% become delirious at some point in the hospital stay. So and that's in internal medicine services. It's much higher on orthopedic services. So it is important to have a standardized program, and this isn't just medical, this is also at administrative and nursing levels. It is important to identify cognitive impairment in hospitalized patients. And there are quite good instruments for doing that, none of which are perfect, but all of which perform reasonably well as long as they're done properly. And the other thing to remember, of course, and I'm sure you know all this, but this is fairly new data. So when Frank and I were in training, this wasn't actually known. And you pick up a textbook of delirium, and it would say delirium is an acute medical problem, which when treated properly resolves completely and the prognosis is good. That's what, in the early 90s, the thinking was. Although even in the early 90s, that was clearly not true, and some of the research was starting to come out that delirium was actually quite problematic. So delirium, clearly increases the risk of dying, so it's about double the hazard of mortality in hospital. And that mortality risk carries out past the acute phase. So it actually carries out, in this meta-analysis, it carries out several months at least, the mortality risk. It's also a very strong risk for institutionalization. So again, people who become delirious have about twice the risk of being institutionalized as those who don't. And it's important to note some Canadian trials, so Montreal, as well as American trials, and these trials are from all over the world. So the institutionalization rate is very real regardless of the long-term care system in which you're operating. So delirium is critically important to identify and deal with and prevent. And then there's a host of other things that are very important to identify and prevent. Pressure sores are very problematic. If you look at long-term care, a very large percentage of pressure sores in long-term care are actually acquired in acute care. So if you're wearing an administrative hat, it's a bit problematic if you're using pressure sores as a quality indicator of your facilities in long-term care, when in fact the pressure sores are getting acquired in acute care. So it's actually important in acute care to attend to pressure sores, as well as to nutrition, poor sleep, uncontrolled pain, incontinence. And then the other thing we should recognize is that hospitalization is a very stressful period for families. So families are very worried about how their family is doing. Delirium in particular is horrifying for families, and they're very stressed out by it. So we do need to understand that caregiver stress is actually important to deal with. Conversely, there's a lot of people you see who don't have family coming in distressed or upset and calling at 9 or 10 at night, worried about their parents. And that might just be because they don't have family. And that's not good either, because it's difficult to look after somebody who doesn't have a caregiver. So we have to understand their social situation. And then I mentioned this, but it's very important, that recovery in all of those domains takes longer than the acute resolution. So we do have to be patient, and we do have to enable time for people to recover from the acute inciting event. So this has been described quite well in some recent papers looking at the post-hospitalization syndrome. So the notion that people are at risk of a large number of adverse outcomes after hospitalization. So the readmission rate is very high, and it's often not readmission for the same thing as the index admission. So this is where people come in with complications. So someone comes in with heart failure, gets diuresed, goes home, comes back in renal failure. Someone comes in with heart failure, gets diuresed, comes back in with postural hypotension and a fall and an injury. So that's a very common situation. So post-hospitalization syndrome is very real and very important, and we need to make sure that after the acute phase, people are not only medically stable, but functioning cognitively stable and have some kind of adequate discharge plan in place. That's actually quite difficult, because you go from being seen once or twice a day in acute care to being seen maybe once or twice a month in family practice outpatients. So we really need to switch the system so that we can have a more continuous care. And one of the things we can do is geriatric assessment and discharge planning. So what is that? This is the traditional definition. There's a bunch of definitions, but this is certainly the most widely used. And the key points are that it's multidimensional. So it's not just medical, it's functional, it's cognitive, it's social, and it's psychological. So it's more than just the medical domain. And the other key point is it's interdisciplinary. So you do require a complete healthcare team to do a proper comprehensive geriatric assessment. And the other key point is that you make a plan, and you communicate that plan with the person and their family. So the first key point is the assessment. And again, it's a bit embarrassing to say, but there are services in Winnipeg that actually don't do histories and physicals preoperatively. So it would seem obvious that a person in hospital should have a history and physical on the chart, and they should be a complete proper physical exam. They should also have a good functional status exam, and you should know their social situation, their educational level, their economic situation, because those are all important in the care of the person. We should know the person we're looking after. The second key point is that we should have some kind of clear objectives and plans. So we should have in our mind what we're expecting to happen and what the patient and their family are expecting to happen, and those should be clearly aligned. So, and that's not hard to do, you just ask. And again, that can be different. So daughters often have different goals than sons, who often have different goals than their parents. So we should know what the expectations are from all of the different people in the care group. Then we should put together a plan. What can they do functionally, and what does the discharge require? and then review that plan and progress. And this is directly cut and pasted from the AGS, American Geriatric Society teaching slides. And this is also directly cut and pasted from the American Geriatric Society, because it is tempting and very important to focus on just the acute illness and just the technical aspects of care. But we do have to focus on the whole person and the whole system of care and all of their family. It's not just decent care, it's actually important in the care of a person. So what are the models of care? Now, a big word of caution, and that word of caution is that no matter where you go in the world, everybody has a different nomenclature. So these are the words, the terms that have been used in research. So I'll use geriatric assessment units in the US, they're called GEM units. That's problematic because in a lot of places in Canada, this is geriatric emergency management. So different hospitals will use different words to define these services. So that's a key problem. And people say, oh, we have an ACE unit in our hospital, but what they mean is they've got a GAU. So I'll come to the definition of what those are, but it's important when somebody says a service that they actually define it because they're used interchangeably. So a GAU is subacute and post-acute care, late acute care. They're usually in teaching hospitals and usually attached to the teaching hospital. And they're for older people who've stabilized during acute care hospitalization, sometimes stable people coming directly out of the emergency department. And the key point is that it's a ward. So it's a physical structure that has a team attached to it. And that allows time for recovery and rehabilitation. That's a bit different than an ACE unit. An ACE unit would be essentially a CTU, staffed at a CTU level with medical staff attending level, taking people who are acutely ill right out of the emergency department. So that would be what, when people say an ACE unit, that's what they're talking about. And then the third model of care that you see often is the Hospital Elder Life Program, and this is an attempt to disseminate the general principles of geriatrics to the whole hospital. So these are services that go around to try to geriatricize or make the hospital more elder-friendly. And this model of care grew out of the delirium prevention studies, where they found that delirium prevention also prevented things like falls and long length of stay if you did it to the whole hospital. So there is a bit of a debate as to which model is better, but I think clearly it's probably a combination of those models that a healthcare system needs. So what are the characteristics? This is just directly cut and pasted from the Cochrane meta-analysis that I'll talk about in a second. It's actually critically important to note a lot of these trials too were Canadian, so David Hogan, Colin Powell. So they are Canadian studies as well as American and British. So the key components that were looked at in the Cochrane review, one is a comprehensive assessment. So again, it's not just a medical assessment, it's also a functional and cognitive assessment. Two, that there's a team, but not only the team, but there's actually a team meeting. So it would, you actually meet together as a team to plan care, not just informally in the hallway. Not always goal setting, but usually some form of goal setting. And then less prominent were assessment tools and standardized protocols. So the key features were a ward environment with a ward team that met and cared, planned care. And when you look at what the team was, again, it was surprisingly similar to 1936. There was, just as a bit of a plug for my specialty, all of them actually had an attending geriatrician. They don't say that from the Winnipeg trial, but Colin is a geriatrician. So they all had a geriatrician, and they all had nurses trained with some extra training in geriatrics. They all had a social worker. Almost all of them had a physiotherapist. Almost all of them had an occupational therapist. And most of them had access to the rest of the healthcare team, pharmacists, speech-language pathologists. Some had dentists and psychology. So you had a full care team. The structure of care, well, one, the environment was conducive to rehabilitation. So large, clear hallways, chairs upon which people can rest, accessible rooms, so rooms that you can get into with a wheelchair, bathrooms that you can get into with a wheelchair, bathrooms that an older person can get in and out of. So again, nothing particularly fancy, but it is important. The other important thing, I think, is a dining room. If you have a dining room, it does enforce ambulation and social interaction, so people are obliged to actually get up and walk 3 times a day and socialize 3 times a day and reintegrate into their daily routine. And then you need a space for rehabilitation that's close by. You need a team approach that I mentioned, and it shouldn't just be sitting together to shoot the breeze, it should be care planning. And then the other key components are early ambulation, attention to hydration, attention to clothing, footwear, and aids, and then reintegration to the normal daily routines. So that's what happens, and then you have to say what are the outcomes and what's the evidence for good outcomes. I'll focus mostly on the evidence for GEM units, so this would be a GAU, what's just down the hallway there, essentially as a classic GAU or GEM unit. And the big chunk of evidence comes from a Cochrane review, so it's a meta-analysis published in BMJ and the Cochrane Library in 2011, and they identified 22 trials of about 10,000 people who underwent a geriatric assessment versus those who didn't. And they found a clinically relevant benefit in the GAU population. So they were more likely to be in their own homes and alive at the time of discharge than people treated in traditional units. And they were also more likely to be alive and in their own home at a year follow-up. So that is good for the person, but it's also good for the system. If they're remaining in their own homes, there is some less pressure on the long-term care system. They also found other benefits, so the cognitive status was better in the people who were treated on GAUs than those who weren't. And they did look for interactions in the effect, and they did find that a comprehensive ward was more effective than a roving consult team. So it was probably not just the team, it was the ward environment that was effective. There are models that use teams alone, so delirium prevention in particular does have some evidence for teams. And those are the forest plots, if you don't believe me. There was a second meta-analysis, again in BMJ, looking at geriatric rehabilitation units. So these would be people who are more medically stable, and these ones were often off-site. So the GAUs were usually in acute care teaching hospitals. The geriatric rehab units were in teaching hospitals, but also in rehabilitation facilities. And again, they found a fairly significant benefit in terms of functional status, both at the time of discharge and at the time of follow-up. They found a lower use of long-term care in the treatment arm. Unlike the Cochrane review, they did find a benefit in terms of mortality. And they looked at different stratifications, and they found that the benefit was there in all settings, but it was actually a bigger benefit in post-orthopedic rehab. And then there was a third meta-analysis. I guess you could meta-analyze them into an inter-analysis or a trans-analysis. So there's a third meta-analysis showing a benefit as well. So this was published in JAGS, Journal of the American Geriatric Society. They as well found no benefit in mortality, but they did find a lower institutionalization and a lower functional decline rate at a year. So that was their conclusion. Now the predictors of better outcome, some of this is observational evidence, but there are predictors that do seem to make for better outcomes. One is actually controlling and integrating the care. Secondly is targeting the seniors, and I'll come back to that. So we get accused of being Goldilocks, too warm or too hot, but cold porridge is not good, and too hot porridge isn't good either. So we really do need to select the right people, and those are people who are at intermediate levels of frailty. If you're really a functionally intact, well 80-year-old who just needs a new hip, that's not the people who benefit from GAUs. It's the people who are intermediately sick, nor do people who are terminal. And then the other important point is that you need to address medical and social factors. Now, the other people who don't seem to fit in the model, who are sort of new to the healthcare system, are these chronic hospital patients. They're not really well defined in the literature, but I think when people say that, most people know who we're talking about. And these are people who go from one illness to the next and back. So people who are really medically stable only for very brief shining moments. So do the house staff know what we're talking about when we talk about chronic hospital patients? And when you say that, most people know these are people who spend a lot of time in hospital going from one problem to the next. And I'm not so sure we're very good at dealing with those people who are persistently unstable. So these would be people who have precipitous flares, who often have end-stage heart failure, often renal failure, and often multi-organ failure. And the second that you stop weighing them every day, they tend to get worse. So that's the evidence. So in summary, frailty is relatively uncommon in older people in the community. It's not uncommon in hospitalized older people. Secondly, a large proportion of disability is acquired in hospital. And three, if we do a better job of looking after people in hospital, we have lower rates of institutionalization, less pressure on the acute care system, and better outcomes for our patients. Now, this is a paper from 1951, which says what I just said. So social problems are usually secondary to demonstrable physical illness. With proper hospital facilities, a high proportion of elderly people, again, we wouldn't say socially crippled by disease today, but we would say disabled by disease, can be satisfactorily rehabilitated for life outside the hospital. If you don't have those facilities, you do wind up with significant levels of disability. So a hospital-based comprehensive geriatric solution is a logical solution to the problem of older sick people. So I think many of the messages in geriatrics apply across time and actually across place. So attention to detail, thoroughness, and attention to functional status are actually important messages at all times in clinical care. So I'll leave it with those statements. And are you going to open for questions, or should I just open for questions? Or?